Hello and welcome to the Growth Paramedic channel. This is your host Marvin, and on today's Clinical Talks episode, we're going to be discussing end-tidal CO2 and a potential usage in our sepsis patients. So let's begin. Can we use low end-tidal as an indicator or a helpful marker for sepsis? We're going to be exploring this potentially useful tool in our assessment and our identification of sepsis. So we're going to start with a case study. We have an 80-year-old female from a nursing home. Reports have come in by the MDT that there was a sudden change in the baseline GCS. There was an altered conscious state noticed by staff at 4 p.m. 000 was called at 7:30 p.m. and we've then arrived at around 8 p.m. So there's been 4 hours of an altered conscious state with this patient. When we arrive, the nurse in charge has stated that the patient was otherwise well in the morning and the symptoms had only begun at 4 p.m. The family were on scene. There was no advanced care directive. And the son, who has identified themselves as the enduring guardian, is telling you that the patient is for full treatment. We will note that the patient was recently discharged from hospital about a week and a half ago for a fall. These were the vital signs, a little bit changed from the ones I obtained, but these were the generalized observations that we've obtained. So the GCS was a 12 made up of E4, so eyes were open spontaneously. A V2, so incomprehensible noises, can't really communicate with this patient. And with enough M6, so the patient could squeeze my hands when I asked them to, but there wasn't much other movement going on, but they were able to follow commands. The pupils were 4 to 5 millimeters. They were reactive, but there was no sense of tracking or movement or any organized tracking that I could observe at the time. The rest rate was 24, and it was immediately identified there was a Kussmaul breathing pattern, so deep inspiration and expiration breathing pattern. There was no ketone smell or fruity smell that I could identify. The heart rate was 120, 130, ECG sinus tachycardia. BGL was 11, known type 2 diabetic on insulin. Temperature was 35.2. The peripherals were cold. She was quite pale at the time, and the cap refill was 5 seconds. SpO2, oxygen saturations, were unrecordable initially. The probe couldn't get a good reading due to the cap refill, and there was cyanosis to the lips, and of course there was a very much a pale complexion to the patient. Blood pressure was 60/50. Very weak radials. There was a carotid pulse present, but quite weak. And end tidal was 6 to 8 millimeters to mercury, and with a good waveform. So from these observations, there was a couple provisional diagnoses that we could potentially go down. Could this be sepsis? Could this be stroke? Could this be diabetic ketoacidosis with a history of type 2 diabetes? Now, if we were to go to look at all these 3 provisional diagnoses, we can probably lean more towards sepsis route, and we will explain that in the next slide. And that was on questioning. So on further questioning of the staff on scene, we found that there was an ongoing UTI that was acquired at hospital since discharge to the nursing home. So there's been an infection, a known source of infection for the last week and a half, and the patient was on their second course of oral antibiotics, which suggests to me that the patient was not responding to the antibiotics and the infection was potentially getting too severe for the body to manage, which kind of leads back to our suspicion that it's probably going to be sepsis. Stroke, potentially, but we can't rule that out. But the history and the observations lead more towards a septic pathway because stroke doesn't necessarily explain why the blood pressure is so low and why the patient is severely hypotensive and cold peripherals. Could explain the breathing problems, the breathing pattern, but even then, a Kussmaul breathing pattern is more in line with something like diabetes or metabolic acidosis, while something like a hemorrhagic stroke or I guess an ischemic stroke would cause something like a Chen stroke breathing pattern. So there wasn't too much supporting a stroke provisional, but more leaning towards either diabetic or sepsis. And we actually ruled out DKA at the time because we had ketones. We determined the ketones was 0.3. And a BGL of 11, it's still, yes, it's on the higher end of your normal levels. In fact, we say 4 to 8 BGL is our normal, but because this patient has a known history of diabetes, I would say 11 is not extremely high enough to meet a diabetic emergency. So we can kind of look towards more of this as a septic patient. So this was our treatment. We treated it as cold urosepsis. The temperature wasn't febrile, but they were cold. And you can have, I guess, two extreme ends. They can either be hyperthermic or hyperpyrexic, or they can be hypothermic. So they actually become colder due to the severe infection, which is an indication of probably a more severe form of infection because the body's response is dysfunctional. Rather than there being a fever, there is no fever. In fact, it's going the opposite direction. So this usually can suggest a worse outcome for these patients where they're septic and they're cold. We got bilateral IV access. The patient had 1 liter of Hartmann's, which didn't do much in terms of raising the blood pressure. When we got to hospital, the hospital blood pressure machine only read about 80/60, so it wasn't a significant increase. Oxygen therapy to maintain oxygen saturations due to unable to get a good SpO2 reading. But the patient didn't have a history of COPD, so we were quite comfortable with giving some high flow oxygen therapy until we can get an accurate reading of the SpO2. An OPA was inserted. Patient was compliant, and this was inserted when we actually got into the ambulance because the patient became bradycardic about 37 to 40 beats per minute, became a GCS of about a 4 to 5, but then that only lasted for about a minute or so, and then the patient kind of returned back to where we were when we first got there. But the patient was tolerating an OPA, so we kept that in. A code 3 was passed to hospital and we transferred into the resuscitation bay, and it was diagnosed with the staff there that the patient did have cold urosepsis. Unfortunately, just due to the nature of how severe the infection was and the fact that, it's been about 4 hours since the sudden, I quote, sudden change in presentation since 4 p.m., the hospital, with the discussion with family that arrived soon after we did, they decided to palliate the patient and provide comfort measures. The patient ended up dying 2 hours later. So why do I mention all of this? Why do I mention this case study? I think it's important to identify, what is sepsis? Because that's going to lead up to why I've mentioned end tidal as another useful marker we can use to assess, could this patient be having a severe infection that's potentially now potentially invaded the bloodstream? So sepsis is time critical. That's kind of the caveat to anything that we talk about in this whole presentation. Early identification is one of the big things we can do in the pre-hospital setting. If we can use our knowledge, our skills, and our monitoring gear to guide us towards an early identification of sepsis for our patient, we can change the outcome of these patients, and we can potentially get them to the help they need in time before they get too severe that end organ failure is likely. I will mention that not all infections cause sepsis, but all sepsis presentations are generally caused by an infection. So that can be something like a urinary tract infection, like this case study mentions. It can be other things like an untreated ulcer in the leg or cellulitis that hasn't been managed very well and it's progressed. The underpinning nature of sepsis is there's an increased metabolic demand and there's insufficient circulation. An infection will eventually cause a dysregulated immune response, our sepsis criteria, and organ failure is the worst case that we can have, and these patients will, of course, die without treatment. So Pathophysiology 101, sepsis is a multifaceted disruption of normal immunological response to an infection. And there is a term that we can use to define the main characteristics of sepsis, and we refer to it as the 4 horsemen of the septic apocalypse. So we have our endothelial dysfunction, so our capillary leakage. We have our decreased tissue perfusion. We have our catabolic state and decreased cellular energy consumption. And we have our left ventricular dilation and hypotension. Now, this all sounds pretty complicated, but the main underpinning factors of sepsis is you tend to have a significant dysfunction of the normal physiology of the body. So the blood pressure tends to drop really quickly. And we often in these patients get a state of metabolic acidosis. So the pH of the blood decreases as a result of sepsis. And that's a very important factor to note because we're going to be discussing how end-tidal can help determine whether this patient is potentially in a severe metabolic acidotic state. Now, when organ hyperperfusion occurs, there's something called serum lactate. Now, serum lactate rises quite quickly, and lactic acidosis will follow soon after, and that will cause metabolic acidosis. And one of the body's physiological responses to try and compensate this increased acidosis of the blood is to increase the respiratory rate to try and resolve this metabolic acidosis. And so there is an inverse relationship between the serum lactate levels and end-tidal CO2. So to summarize it in the second point, as lactate rises, carbon dioxide levels fall, and end-tidal levels have been shown to be an accurate predictor of mortality in patients with severe sepsis and septic shock. And so an end-tidal of CO2 that was less than 25 millimeters to mercury was strongly associated with serum lactate levels of greater than 4. Now, why is that important? Why do we need to know that an end-tidal less than 24 can suggest a serum lactate levels of greater than 4? Well, if we're thinking about a patient potentially presenting with an infection, a serum lactate level of 4 is considered to be a reliable indicator of metabolic distress and can present before hypotension even occurs. So this can be a very useful monitoring parameter even before our patient who we think is having a severe infection shows an organ dysfunction through our hypotension, tachycardia, and all those other severe end stage levels of our septic patients. And so the benefit of capnography in our septic patient is that it allows us to measure respiratory rate quite well in comparison to visually measuring the respiratory rate. I have to say, not everyone, and I myself can be sometimes really terrible at it, but we don't often measure the respiratory rate quite well, or at least get an accurate measurement. It can be hard at times because the patient may be breathing quite shallow, there may be clothing in the way, or there may be excess adipose tissue that doesn't allow us to really appreciate the rise and fall when they're breathing. In a septic patient or someone with infection, assessing the respiratory rate is a significant factor in guiding us towards, is this patient meeting, for example, the Q-SOFA criteria or the SIRS criteria, which all include an increased respiratory rate. And so being able to use capnography that has a good waveform can tell us straight away that this patient is either breathing too fast or breathing too slowly. As well as that, end-tidal can allow us to see what the CO2 measurements are currently with that patient, and in, I guess, a case of sepsis, potentially guide us towards, is this patient in metabolic acidosis? If the end-tidal measurement is less than 25, we could then start to consider, well, the lactate levels may be above 4, and this patient needs to go to hospital to get a blood test done and to confirm that this patient is having a severe infection. Kussmaul breathing is something I mentioned in the symptoms that were observed for that case study. And it's often, I guess, confused as simply only being there with our diabetic ketoacidosis patients who have high ketones and they need to breathe all of that out. One of the things we need to also consider with Kussmaul breathing is sepsis. Lactic acidosis will result in metabolic acidosis, and the patient will compensate by trying to breathe out all that excess to try and resolve the increased acidosis of the blood. So you can see a deeper inspiration and a deeper expiration. So kind of rhythmic, deep in and out breathing pattern of these patients. And if they're not in a DKA or suspected DKA, you need to think, could this potentially be a result of the infection? Now, this concept isn't relatively unknown. I mentioned here in the SIRS criteria and the Q-SOFA criteria that a arrest rate and, I guess only just arrest rate really is included in both the SIRS and Q-SOFA criteria. So end-tidal capnography really allows us to quickly identify in an objective way that the respiratory rate is indeed above the normal threshold or is meeting that threshold for potential sepsis. So this is the current research around end-tidal and using it as maybe a helpful marker in sepsis. End-tidal CO2 has a higher discriminatory power to predict mortality, sepsis, and severe sepsis than Q-SOFA. End-tidal of less than 25 in patients with suspected infections is diagnostic of sepsis and therefore could be used to increase the speed and accuracy of diagnosis and potentially reduce sepsis mortality. I will notice in the second research that's mentioned, we as pre-hospital providers, as paramedics, we can't actually diagnose patients. What we can do is have a suspicion and potentially provide a provisional diagnosis. Any diagnosis of a condition should be done at the hospital where all the tests can be completed. And the third one is a significant inverse relationship between end-tidal CO2 and lactating children presenting with sepsis. Children in particular are very important demographic when it comes to sepsis. There's an increased risk of them deteriorating quite quickly, and things like a respiratory infection can quickly lead to sepsis if not identified early. So if you have a child presenting with infection, I'd always recommend, if they can tolerate it, to put some end-tidal on them and to observe what the readings are saying. Now, some pitfalls to be mindful of is capnography should never be used or analyzed on its own. This is known as anchoring bias. If we simply look at the number without context, we can very easily fall down a tunnel vision approach to care. Capnography should always be done as part of a comprehensive patient assessment using all your vital sign metrics, so your blood pressure, your respiratory rate, your heart rate, your ECG, your SpO2 monitor, and your sugars. All of that should be done in the context of additional history taking, because capnography can show a whole range of different things. And if we were simply just to be looking at the end-tidal by itself, we can very easily go down the wrong route and, of course, potentially have a bad outcome. So it's just one extra tool you can think of when you're going down that path of, is this patient having an infection and how severe could this be? Because if we put end-tidal on and it's lower than 25, there's an increased rest rate, that's Kussmaul breathing pattern, we could be more concerned that this patient is in a state of metabolic acidosis caused by severe infection, and the serum lactate levels could be greater than 4, which means that if we don't do something now, the patient will have a bad outcome. As well as that, reduced blood flow from hypotensive state can result in a false negative, less CO2 being transported. So in our patients with sepsis, they can be severely hypotensive, and because of that, there's actually less circulation going, so less CO2 being transported. So if your patient's really hypotensive, you may get initially a very low reading, which is what we did when we had our patient who was 6 to 8. Now, after we gave 1 liter of Hartmann's, that end-tidal did actually go up to 23. But remember, less than 25 is still indicative of serum lactate levels of potentially 4 or greater, so there were still great concerns that this patient was in severe metabolic acidosis. Now, why do I discuss end-tidal? So let's summarize this clinical discussion or clinical talks. The use of capnography is relatively new for, let's just say, the service I work for. But if you do work in a service that has used capnography, it's another helpful parameter or metric we can use to guide clinical judgment towards a sepsis identification. Remember, the underpinning goal that we have as pre-hospital providers and pre-hospital clinicians in the sense of sepsis is that we need to be able to quickly identify it, which allows for earlier treatment, which allows for better outcomes. Had this patient been identified earlier with a progression into sepsis at, let's just say, 4 p.m. or sooner, that patient may potentially had a better outcome than what the patient had. So patients with suspected sepsis always require immediate resuscitation. By the time someone presents with sepsis, they were already going down that drain, and so we need to start working on them as soon as possible. And weird enough, end-tidal, when it increases and rest rate decreases, that can also be an indication that the patient is no longer compensating. And we now need to consider this patient is potentially peri-arrest. So it's a useful measurement to determine a worsening, deteriorating state for our patients in sepsis. Well, then, guys, that ends the presentation today. Then it's the clinical talks. If you have any questions and comments, please feel free to put them down below the video. Have a good one and see you next time.